Okay, ji, Assalamu alaikum everyone, and a very good morning to all of you. I'm Dr. Sadia Waheed Khan, and I'm working as a fellow of pain medicine at Evercare Hospital, Lahore. On behalf of the organizing committee, I'm privileged to welcome such an esteemed group of physicians from all over the world who are united by a shared passion for advancing the science and practice of pain medicine. We have an exciting program lined up comprising of speakers with insightful minds. Without further delay, let's start our first session of the day, which is chronic musculoskeletal pain. Ladies and gentlemen, I am going to introduce our distinguished chairperson of this session, who holds wealth of knowledge and expertise in this field. He is Pro-Vice Chancellor, People's University of Medical and Health Sciences for Women, Nawab Shah. He is Professor and Head of the Department of Anesthesia, Surgical ICU and Pain Management Center, People's University of Medicine and Health Sciences for Women, Nawab Shah. He is founder of First Pain Center in the interior Sindh. He is member of Faculty of Anesthesiology at CPSP, Supervisor and Examiner of FCPS Pain Medicine. Please join me in welcoming Professor Dr. Muhammad Saleh Khas Khaili, sir. Thank you. Our next chairperson of this session of chronic musculoskeletal pain is Dr. Athar Mukhtar Siddiqui, who is consultant anesthesiologist at Evercare Hospital, Lahore. His area of interest is acute pain management and obstetric analgesia. He has worked at NHS as a consultant for a number of years, and he has various publications in regional anesthesia. Dr. Athar Mukhtar Siddiqui, please. So let's start our session with the first speaker, who is Dr. Usman Bashir, on the topic of navigating the narrowing and evidence-based update on spinal stenosis. He's leading the pain services at King Faisal Specialist Hospital and Research Center, Madina. He set up multidisciplinary pain center in National Hospital and got it recognized from CPSP. He is an active member of CPSP faculty to set up the curriculum for pain fellowship and has been actively collaborating with Royal College of Anaesthetists London and WFSA. Please, Dr. Usman Bashir.
Assalamu alaikum, everybody. Thank you so much to the faculty for inviting me. The topic I've been given is very exam type topic, so next 15 minutes will be kind of a revision for you, but we'll try to make it interesting and from basically navigating the evidence base which is available. So I don't want to convert into a theoretical topic and revision for you. I wish if more junior trainees were here to listen to what works, what doesn't work, and what we should be doing as a pain physician. So this is the place where I work. King Faisal Hospital, Madina. It's a beautiful hospital, newly built, and we have a challenging task of setting up the entire pain services for the whole region, which is not just Madina city, but it's the whole Madina province, which is a huge area. So this is the talk scheme, which is pretty straightforward because it's a straightforward topic. But when we come to this, an elephant in the room, which we have to get out by the end of this session. By this, what I mean is treatment. So what should we be doing for this? So hopefully by the end of this session, we'll try to get the elephant out of the room, which has been in the basement of Dr. Khalid's new built pain center. So let's start. Very briefly, I'll go through anatomy, pathology, diagnosis, but administration can warn me about 6 minutes warning so that we come up to the treatment part. That is where I want to spend more time on. So it is an anatomical condition. There is a narrowing either in the central canal or in the lateral recess or in the neural foramina. Most commonly, the pathology is degenerative. So keep that in mind. It is not inflammatory, it is degenerative. And there are other causes which we'll come to, but keep that in mind as a take-home message. So this is a beautiful looking lumbar spine which we are all aware of, nicely looking nerve roots, good space around, posterior elements, anterior elements, beautifully looking disc. Okay. What we have to navigate today is how from this it goes on to this. What is the pathophysiological mechanisms involved, and what is the background of all this pathophysiology, and why some things work and some things don't work. So all components are related to each other. So what is happening as a first event? We are talking about degenerative lumbar spinal stenosis because degeneration is the most common mechanism. So first step in the pathology is the disc dehydration with age and with risk factors, disc is becoming desiccated. As a result of that desiccation, there is more load on the posterior elements, more strain on all the posterior elements, facet joints, ligamentum flavum. So as a result of those increasing load over the number of years due to this dehydration, what happens? There is compensatory hypertrophy of posterior elements, which as a result cause overall narrowing over the number of years. So remember, we are not talking about acute radiculopathy here. We are talking about degenerative spinal stenosis, especially for trainees and residents, so that we keep it in mind when we talk about treatment. Keep in mind this picture because this is relevant to our treatment options, especially this area, conus medullaris and cauda equina. Because if compression is acute and in this area, that is the only grade 1B evidence which we'll talk about in this category in terms of treatment recommendation. Everything else is 2C recommendation, that is weak recommendation in terms of evidence base. So that's why keep in mind this picture. I'll quickly skip through that. Etiologies, as we have spoken about, mostly it is degenerative, mostly it is above 60 years old. Progressive degeneration leads to compensatory hypertrophy of various musculoskeletal elements, which results in narrowing. And narrowing can be in either center, lateral, or the spinal column. This is also important because treatment is related to that. Spondylolisthesis, which simply means one vertebra is anteriorly or posteriorly transforming, causing the narrowing. So this is related to the treatment. Other theoretical causes you have to be aware of. There can be any space-occupying tumor, congenital anomalies, which can cause the narrowing. But practically, what you will be dealing with mostly is the degenerative arthritis-related narrowing. This is very interesting. Now we'll come to the mechanisms, that what is actually happening. The reason it is interesting because it is related to our treatment options. And I was very interested to find the evidence base for that. The number of papers which have come across, mostly in 1970s, 1930s, 1980s, I'll just present the summary of all these papers, that the basic discussion here is whether the mechanism is mechanical compression, ischemia, or it is inflammation. So the outcome of all the evidence which is currently up to date is that, yes, there is mechanical compression and there is ischemia, but there is no inflammation. So that is important when we talk about treatment. So the pathophysiology, I'll spend a couple of minutes on that. So there is either direct compression or there is indirect compression due to increased intrathecal pressure due to narrowing. So that is the physical compression part. But as a result of increased intrathecal pressure, there is venous congestion. There is reduced arterial supply, blood flow. And that results in reduction in the blood supply to the nerve rootlets. And the studies have shown, as a result of that reduction, there is mismatch in microvascular blood flow, especially when it comes to activity. When you're standing up, when you're walking, then the supply-demand mismatch occurs, and there is ectopic firing from the nerve roots. So there's a combination of intermittent mechanical compression plus ischemic mismatch, and due to that, ectopic firing. And that explains one of the main symptoms as well of spinal stenosis, that whenever you erect an extended posture, all your posterior elements are further buckling, further reducing the space, okay? So as a result of that, that supply mismatch is further enhancing and causing further narrowing. So these are a couple of more studies which looked at all these things which I have presented here, that they did studies and found out that when somebody with spinal stenosis walks, there's higher pressures in the epidural space, and the symptoms were explained by those studies. Another interesting study, they did myeloscopic study in the proven lumbar spinal stenosis and found out that whenever somebody makes any postural changes, there is difference in the blood supply of cauda equina. So all very interesting studies. We just quickly skip through the clinical presentation part because most of us knows about it, but it will be a very quick revision of the symptoms. We know that the hallmark is neurogenic claudication, which is pseudo claudication, which is not vascular claudication. We'll talk about it. The hallmark of that is that it is often bilateral. Weakness is there. It is asymmetrical. The symptoms often are distributed in multiple nerve root territories, so it's difficult to pinpoint to one nerve root territory. And they get better when the person sits down or flexes forward. Again, that is related to the pathophysiology we studied. So some studies, interestingly, found out related to that as well. So that is very good. Older studies, but still they studied the evidence base for that. They studied about 800 patients in a systematic review to find the actual symptoms of the disease, and they found that most patients have this neurogenic claudications. Most patients are relieved by flexion at the waist side. That's why the bending down on the cart sign is a classical for spinal stenosis. And it is the combination of these findings which will help you diagnose. Now, this is important because in spinal stenosis, a lot of diagnosis is clinical as well, apart from radiological. Again, another study which looked at the pain symptoms, that what is happening. Pain is there in 93% of the patient, numbness is there in 63 patients, and mostly it is bilateral. Examination is mostly normal, but the take-home message from examination is that you have to pick up where you need to act, and which is this cauda equina syndrome, and if the site of compression is between T12 and L1, then spinal cord is still there as conus medullaris. So then you will get mixed picture of myelopathy as well as cauda equina. So the only purpose of examination is you pick up the red flags. Rest of the every patient is more or less like you'll pick up some neurological deficit, but these are the two cases where you have to act, I'll spend a couple of minutes on that. Differential diagnosis, especially for our fellows and residents. This can be tricky, although it sounds very obvious, but sometimes it can be tricky. So you are mainly differentiating from vascular claudications and other differentials because patients have not read the books. In elderly patients, sometimes conditions can coexist, and that's where the diagnostic dilemma comes, and we have to do some more investigations. So both pains get worse with activity, both pains get better with rest. But neurogenic claudication, as we saw the pathophysiology, when you stand up from sitting posture, gets worse. But vascular claudication, if you are standing and not doing activity, will get better, okay? Neurogenic claudication gets worse standing up, gets better when you're leaning forward on a cart. Neurogenic claudication, classical sign. They love cycling. So all elderly people have spinal stenosis. They can lean forward on a cycle. They can use it in activity. But if the same condition following with the vascular claudication, they will start having pain because muscle is in use, vascular insufficiency. So that's a quick table which trainees can take a picture of just to help you differentiate between the two when the patient comes in the clinic. Other differentials are there, and you will come across them once in a while or more commonly in the clinic. Diabetic polyneuropathy, osteoarthritis hip, non-specific back pain, they all can manifest the same type of pattern. But your key diagnostic criteria will be those which I have explained in the clinical symptoms. For completion, these are other conditions which can cause amongst the differentials, so that if you get any rare patients, you can move on to that. What about diagnosis? It requires clinical examination plus radiological findings. But some key tips for our young fellows as well that do not primarily rely on MRI alone. You have to make a relationship between radiological findings and the clinical symptoms. The reason for that, a lot of time you will have incidental finding of stenosis even in normal patients. So that's a good study where they studied about 98 asymptomatic patients, and they found that 52% had at least narrowing at one level, 38% had more than one internal level, and they had no symptoms at all. So don't get excited just by seeing the MRI only. always correlate. MRI is the imaging of choice. However, when MRI is contraindicated, you have to do CT scan, CT myelography. You will administer contrast if there is any post-op complications suspected, hematoma, fibrosis, or any neurological acute emergency. This is something interesting I found while searching the evidence that Americans have been doing dynamic dural sac cross-section examination. By that, what they mean that they are creating axial load, and then they are seeing how much is the degree of stenosis by measuring the dural cross-sectional areas. Something which existed there as a study, but I don't think so it will be practical, but I just thought interesting fact I found in the studies. Quickly, this is more of a radiological area, but just you should be aware of that. There are different diagnostic criteria, but none of them have any superiority over other. There is no consensus on one, and studies have found that there is inter-rater variability in reporting the area. The commonly used ones used are Lee and Shiza's grading system. Again, it's radiological realm, so I'll not dig deep into that. What we need to know is the grade D is the very severe stenosis, which is unlikely to respond to our treatments. You will do other diagnostic tools only if you have confusion for diagnosing, that you're not clear about whether it is vascular, whether it's polyneuropathy of diabetes causing these. So then you will do some additional tests to clarify your diagnosis. But the key take-home message is that you have to identify the patient who need urgent diagnostic evaluation. So what I'll do now, I skip to the part which is more tricky. This was a straightforward part. And that is prognosis and treatment. And I'll talk more about non-surgical treatment, and I'll talk more about that elephant again, the epidurals. We have to think from patient's perspective. Patient is coming to you in clinic and asking you all these questions, and you have to be able to answer them in an informed way from the evidence that this is what will work, this is what will not work, and then you have to make an informed decision. So patient will first ask, what will happen if I don't do anything? Is this a serious condition? So patient is asking about prognosis, natural history. The evidence says, okay, most of it is degenerative arthritis. Nothing will happen. Yes, but there will be effect on your quality of life. The only exception is serious pathology. You have to pick it up. So most patients remain stable over a number of years. There has been evidence for that. There have been studies which followed the patient for 4 years. And that's what they found, that 70% of the cases remain unchanged. 15% showed improvement, and 15% worsened. So you can tell exactly the same figures to the patients to help them make an informed decision making. This study looked at the patient's perspective, that what do they want out of treatment? Again, a patient-centered approach. They looked at nearly 300 patients. Patients prefer walking with less pain compared to the distance walked. What are my treatment options, doctors? So now we have to tell them from evidence-based what works, what doesn't work. So again, you have to triage. You have to rule out the patient who needs urgent attention, and then we'll talk about the treatment options. Very quickly about these recommendations, that 2C is weak recommendation, 1B is strong recommendations, okay? So these are the non-surgical treatments. We all know about them, but the evidence which exists is good quality, like the systematic reviews, but none of them are high quality enough to recommend any one over the other. This is the overarching evidence review from the systematic reviews done on all the conservative treatments. Another study, Cochrane Database Review 2013, unable to find moderate or high quality evidence. Therefore, any specific treatment recommendations cannot be made. So that is a starting point, so you can understand where it is going. That's why it's the elephant in the room. So a recent article in BMJ suggested, related to specifically spinal stenosis, that non-surgical, they cannot recommend any specific things. Physical therapy, lots of papers are there. It is one of the mainstays, but evidence is difficult because the regimes are not standardized. So most of the physical therapy regimes are targeting on strengthening the muscle, and the concept goes back to our pathophysiology, that they are aiming to reduce the amount of lumbar lordosis so that there is less narrowing. So they are strengthening the muscles. The only thing which evidence says that has been a bit robust. It's obvious that post-operative physiotherapy after lumbar surgery, it is better for them for recovery. None of the other physiotherapy evidence is robust enough, but it is all indirect. If you lose weight, it is better because you'll have less strain on the muscles. If you put the abdominal corset, it is better for you. So I'll quickly skip the pharmacotherapy part. Basically, for stenosis part, only evidence is for pregabalin. And they showed that small randomized crossover studies, and they found no more effective than placebo. So, but I'll come to this elephant. Okay, we have to get this elephant out of the room. Epidural steroids. Okay, so just allow me to go 1 minute over, so just so that we cover the important part. We all know epidural steroid can be injected through translaminar, transforaminal, or through caudal approach. Quick revision. The summary of the evidence from all the studies is limited. Most studies include a heterogeneous patient population. By that, what they mean, they had the patients both with radiculopathy and with spinal stenosis. So they could not make definitive conclusion, except for more recent studies which have looked into this particular part. I'll go from from chronological order back from 1985s when the evidence has started up to 2022 when I found the last evidence related to that. This study looked at patients who had saline or local anesthetic. No statistical difference. So poor quality study, only 73 patients. So, but they concluded that there is no benefit from adding steroid. We'll move to more evidence now. 1995, a systematic review. But the systematic review, there were lots of flaws in the design of studies. So results were inconsistent, but they found that efficacy of steroids has not been established. We'll move on to further evidence. They looked specifically at elderly population, 75 who had MRI-proven lumbar spinal stenosis. Again, a small quality study, only 30 patients with 10-month follow-up. This is the only study which gives positive recommendations only for a subgroup of patients who have poor response to other conventional therapies and poor surgical risk, that they cannot be offered surgery. They can be offered caudal epidural as a reasonable therapeutic options amongst these select patients. But again, it's a small quality study. This, again, is a 1998. They looked at 3 subgroups. They looked at one group they give saline, other group they give lidocaine, and the other group, third group they give lidocaine with steroid. And between second and third group, they did not find any difference in terms of the response. So they concluded that adding steroid does not add anything, which goes back to our pathophysiological theory, that there is no inflammation. So why are you adding steroid? It is not of any benefit. This is one of the latest studies which I found in the evidence. Again, only 128 patients. The way this is different, they looked at the difference in the radiological stenosis, and then they categorized the patients. And they looked at the response to epidural. They found that if somebody has moderate stenosis, they achieve better outcomes. But the follow-up is only for 2 weeks. So does it make a difference? 2 weeks, short duration. Now we come to slightly better studies. I'll just finish in 2 minutes, okay? Sorry. These are now better big studies. Sport trial, which was a big trial. In that, they did a subgroup analysis of patients with stenosis. And they found that patients who received epidural, somehow there was more proportion of these patients going to surgical treatment. It means that epidural did not make any difference. So they had to move over for the surgery for these patients. And 4-year follow-up showed that there was significantly less improvement. So this is a long-term follow-up study, good study overall. This was a proper landmark paper which came out as a systematic review, which did kind of final conclusions related to that. They looked at 8 RCTs related to spinal stenosis. Most of them were for radicular pain, not due to spinal stenosis. For stenosis, they concluded there was no clear effect of epidural steroid injection. Strength of evidence, however, was low to moderate. For radiculopathy, it did show improvement for up to 3 months, but not long term. By long term, this study means 1 year. So there is response in this group, but there is inconclusive response in this group. And they concluded that limited evidence suggests that there is no effectiveness for spinal stenosis. What about number of injections? There is conclusion that we should not be doing more than 3 injections in a year. And we as physicians should keep in mind and should tell our patients that this is another study which looked at 3,000 patients and showed that with every successive steroid injection, the chance of getting a vertebral fracture due to osteoporosis increased 1.21 times, 5-year risk time. So as long as patient is aware of that risk and they're willing to take that decision, then there's an informed decision. That is fine. But you must tell this as a clinician to the patient. So quick summary to get that elephant out of the room. The best evidence benefits come from radiculopathy for epidural steroids. Limited available evidence does not support the use of epidural for stenosis for long-term benefit. Some patients in whom surgery is not beneficial and who are not a candidate for surgery, you may attempt one trial of epidural injection, and if there is relief, then you can offer them more attempts. But if there is no relief, don't offer them more injections. So elephant is out of the room, replaced by this beautiful flowers. So I'm relaxed. So I'll just quickly finish by surgical treatment because it's not our domain. I'll just skip through the part. The most important part in that is patient selection, that you rule out the patients from the studies who have negative predictors. Surgeons should have careful selection for those patients. And the positive predictors are those. Again, these are shown by the studies. This was an interesting finding, again, radiological, that patients who have positive sedimentation sign with MRI are less likely to improve with conservative. Again, something between radiologists and surgeons. This is taking home message again about the timing of surgery. The only grade 1B recommendation is this area in this entire topic, and this is this category. That's why you have to pick up the patients with cauda equina, progressive neurology, or cauda conus medullaris syndrome. Everything else can wait, and it's an elective decision, informed decision. What patient wants, and after understanding all the risk benefits. So the conclusion of all the evidence after looking at 10-year studies is in the absence of neurological deficit, delaying surgery is better. Try conservative treatments first. Don't jump up to the surgery. If spinal stenosis is with spondylolisthesis and instability, then you will do instrumentation with fusion. If it is without spondylolisthesis, then it's simple laminectomy. So this is what I mean by spondylolisthesis, anterior to posterior slips. Again, it's a surgical domain, but bullet points you should just remember from that. And the outcomes are similar from minimally invasive versus laminectomy in terms of overall long-term outcomes. And the benefit from surgery is lost after 4 years. That is also important. Surgeons should discuss that with the patient. So that is all about my talk. I hope I've bombarded you with a lot of information, but that was the nature of this topic. I've tried to get as much evidence as was available in the literature up to the date. And these are my conclusion. And this is the only grade 1B recommendation. And this is, again, in the absence of neurological deficit, opt for conservative treatment first. Thank you very much.
Do we have questions from the audience? We can do it at the end? Okay. Sir, I really appreciate the depth of research you had put behind this topic. Our next speaker is presently working as a consultant in pain management and anesthesia at Sheikh Khalifa Hospital, Abu Dhabi. He had been instrumental in setting up and running multidisciplinary team clinics for pediatric rheumatology and cancer patients in UK. And he's going to talk about interdisciplinary approach to lower back pain and fibromyalgia. Dr. Atif Wali.
Assalamu alaikum. Good morning, everyone. So I'm Atif, and some of this talk has been covered yesterday. So I would say there is new perspectives to be added, and there'll be my personal perspective as well, like any other speaker's presentation would. So we'll keep it within the 20 minutes. To make the talk more meaningful, with the permission of the organizers, I've decided that we'll convert it into an interactive session, if that's okay with the audience. So what I would request is feel free to make any comments, any questions, anytime. There'll be time at the end as well, but use this time as well, because we'll have a slide put up. I'll share my ideas about it. If you have something to say, please raise your hand. And I think you can be heard even without the microphone. And just keep your questions and comments brief. So we'll spend some time on this first slide. This is where I work. This is beautiful architecture, as you can see. But what's more important about the slide is the conflict of interest. And I would say, I would like to know what everyone else feels. Is there a potential for conflict of interest when I say my hotel stay has been paid by the organizers of this conference? Any raise of hands, please? So everyone agrees to each other that there is no conflict of interest, no potential for conflict of interest here. But I would say, I disagree. I think there's a potential of conflict of interest. Even though there is no commercial organization involved here. I'll explain why. So this is this conference has been organized by a professional body. It's one of the many professional bodies that represent us. And I'm an independently working. I'm employed by somebody, and I'm bound to the regulations and the professional ethics and conduct through my affiliation to various professional organizations as well as regulatory organizations like GMC in the UK or SEHA in UAE or PMDC in Pakistan. But I may have not, I'm not saying I have, but I may have a criticism on something that is some aspect of IASP's conduct or the role they played or something they could have done better. And that could have been, since STSP, which is the Pakistani chapter, is part of, so maybe I disagreed with something, the way STSP fulfills its role within the professional. I'm not saying they are, but if I had, I may not be able to say it. So therefore, I believe that it's important that we look at conflict of interest whenever we critically appraise a literature or listen to somebody's presentation, and therefore I've made this. Now, as I said, I'm going to try and add a different perspective to interdisciplinary way of working. So I would say that there are various interdisciplinary. There's never going to be one structure that we can all follow from one part of the world to another and say this is how an interdisciplinary clinic for pain management should be organized. A patient comes in, gets seen by a psychologist, gets seen by a pain specialist, gets seen by so on and so forth. It will have to be in the context of the resources available, context of the culture of the place, of the organization you're working for, or maybe it's your own personal clinic. But interdisciplinary way of thinking is something not unique to pain management. It is a thought. It's a process of thinking. We'd be lucky to be living in the era of scientific rationality, which allows us to critically look at what works and what doesn't work. And we apply the scientific methods and scientific rationality. And that is also not a concept in isolation itself. That is related to the cultural context. So, we know this era of modernity, when the Industrial Revolution, it also gave us wonderful stuff that we all consume on a daily basis, but we also had institutional way of thinking, and that was based on scientific rationality, especially in our profession. So we are going to talk about the complexity of this idea and how it affects us in the world of pain management related to low back pain and fibromyalgia. So it's a complex situation. As you can see, this one of the patients got very funny idea about how her pain affects her. We talked about what is the difference between a multidisciplinary and an interdisciplinary approach. I'm not going to spend too much time, but interdisciplinary is more, I would say, of a vertical organization as opposed to a multidisciplinary, which could be more horizontally organized. So different professionals converge on the clinical opinion when it comes to the clinics. Also, it has to be reflected in the institutional or way of thinking as well, or within the professional bodies, etc. Basically, what it is based on biopsychosocial model, which is a movement started in 1973, and some would argue that it is applicable to most fields of medicine, especially to ours. So now, what is interdisciplinary approach or interdisciplinary way of thinking? It's the ability or the capacity to entertain the idea that there could be more than one form of truth that exists. So, excellent presentation, by the way, the preceding one where we had an elephant. So the famous analogy with the elephant would be somebody sees its trunk and think that's the elephant, somebody sees its tail or body and they think that's the elephant. Whereas in their own right, everybody may be right, but that may not be the whole truth. So that can be kind of explored further by a pluralistic rather than, for the lack of a better word, a tunnel approach, just confined to the limits of what your own thinking is. And that is a way of thinking, or formally studied way of thinking, which is called epistemology, where you look at the origin of the discipline or the knowledge and its construct and its methodology. So epistemology is study of a way of study or a scientific discipline. And to understand that, we think there's like different disciplines which work within their own limits of what their body of knowledge means, like, you know, what they were trained in. So physiotherapists would be trained in a slightly different way, psychologists, occupational therapists, and so forth. But when they all converge dealing with the same problem, they may bring with them a certain perspective that they may have, right? So that leads to an interesting theory that's been discussed in various ways in the popular publications, like popular literature, not strictly scientific, but interesting one is the theory of the broken window. So you see a neighborhood where the windows are broken, and you also find that the crime is high in that area. Now, a very simple approach may be that the cause and effect kind of thing. You may think, well, because the windows are broken, the crime is high. If you fix the windows, the crime will go. And guess what? To some degree, it's true. You can reduce the crime maybe a tiny bit. Actually, there's studies showing that actually happens. But that may not stop the crime. Because as we all know, as anybody would know, the crime has got nothing to do with just a broken window. It's very deep-rooted in human behavior, in the way the societies are organized. And this is not a talk about that. But so you got to live with that reality, that we can see the reality with either a way which is referred to as dualism, so it's either true or it's not, or relativism, which is, everything is just an opinion, or critical pluralism, that when there is sound evidence, we should believe that's true, and that sound evidence may come from more than one source. And it's that capacity to be able to entertain that, and more than that, the capacity to be incorporated into our conduct, and our conduct would be in our practice. And what we find is, I'm sorry, I'll have to go to another slide at the moment and come back to this one. So why it's not as straightforward to be able to translate or reflect that pluralistic thinking into our way of working. And that is because a clinic consultation is not simply an interaction between a doctor and a patient. We see that there are many stakeholders. Now, can I ask the audience, is there some stakeholder that is missing? Please have a look at it, and can you tell me if there's any stakeholders that are missing? Can anybody add to it, please? Yes, please, go ahead. Patient. Well, let's have a look. Oh, the top one is the patient with the bad back. So, well, think again. Well, if nobody else is going to volunteer, so there may not be, there may be. You know, if you think hard, you'll come up with something else. But the point I'm trying to make is, it's a very pluralistic interaction. It's not a binary interaction between a doctor and a patient. And what happens to a patient in terms of the treatment they get, what our aim is ethically and also, you know, humanely and professionally, to be able to provide the best treatment available within the constraint of resources and everything. And that is, we have to understand, that is not dependent only just what you think or what you've concluded through, you know, by attending conferences like this and reading the journals and you know, having a degree and everything and getting the training. So you may not be able to do, because there's many other stakeholders. And that includes the government, the job of which is to act as a regulatory agency to be able to make sure that everything is, is in the best interest of the society. And the society comprises of more than just the patient. I mean, it has patients as a subset, but that's more than that. So just to say that we got to think of the stakeholders here. And by the way, well, can somebody tell me, now there's a question, pharma and medical tech industry, could they influence our practice? Oh, yeah, Dr. What does everybody, can we have a show of hands for this one, please? Just one time interact, please. They could, so only 3, 4, Dr. Cardosa, 5, 6, 7. So majority thinks that the pharma industry and the tech industry cannot. Well, I mean, there wasn't a show of hands. That's what I'm saying, based on showing of hands. Okay, the question is, do you think that the pharma industries and the tech industry, the technology, there could be whatever, I'm not going to name any names here, can they influence our practice? Yeah. So, okay, so that's great, because if some people think they cannot, I would refer them to reading a book called Bad Science, and the author's name is Ben Goldacre, and he was a regular contributor in the newspaper called Guardian in UK. And he wrote a fantastic book, I believe. And that influenced my practice, reading that book. And my conduct as well, about what I do in my career. So fortunately, the book was printed, and I read his articles before that, but the book came out the same time when I was becoming a consultant, and I joined the Research Ethics Committee, one of the local Warwickshire Research Ethics Committee at the same time. So a lot of stuff that he writes about in the book, I actually saw it happening, you know, because I found, you know, this is an area of Birmingham where most of the research coming to us was not great quality if it was coming from the clinicians. Like, it was wonderful research, you know, great effort put into it and everything, but the resources needed to really conduct an RCT or even the selection of topics, as opposed to the research that was sponsored. So I very closely was able to look at it at real time, and I could draw my conclusions of what I need to do. As I said, I have all the respect for the institutions and for the professional bodies, and we're blessed to have them, you know. But there's a trade-off when you become very closely aligned to any. I mean, I'm already employed. I'm already registered with, say, you know, PMDC, formal regulation of the profession. So the more organizations I become an office bearer of or very closely aligned to, it's a trade-off between giving up my independent critical thinking. And that is what I'd like to come back to. So the critical thinking is not being negative. It's not being negative about the role of others or the contribution from others, but it is being able to appraise it with the tools available to us in terms of like rational thinking. And going back to the simple theory of broken windows, to understand a complex phenomenon, sometimes you have to spend more time and get the information needed to construct the right answer for yourself, if not everybody else. You may have to look at outside of the traditional prescribed ways. As an example, I alluded to this book. We all know about the opioid crisis in US, and that's a tip of the iceberg, because that's not just one country where their government was effective in terms of FBI, is it? Yeah, one of the investigating agencies bringing to court the case against a pharmaceutical company. And I'm not being derogatory, I'm not making any allegations, just stating some facts. The pharmaceutical company involved had to pay $8 billion, pleading guilty on criminal counts as well as civil. So there was, I think, 3 main counts, and they pleaded guilty to all 3. $8 billion they paid in fines, dollars. Pakistan's health expenditure is $3 billion or $4 billion, something around that mark. That should give you an idea of what a huge money spinner the pharma and tech industries are. So it's worthwhile for us, because these are lives at risk. Opioid crisis meant a lot of lives lost, a lot of lives wrecked, a lot of jobs, a lot of people becoming redundant, a lot of families, a lot of kids having to deal with their parents becoming addicted to prescription drugs where there were better treatments available. Why interdisciplinary for back pain is more important? I'm trying to make sense of everything here. It may take a little bit of a scenic route, because these pill mills, as they like calling them in the US, were single clinician clinics, most of them. They were not interdisciplinary clinics. And whenever there were interdisciplinary clinics, there was less of irrational opioid prescribing. Very important, very important. I mean, as somebody very clever once said, I'll go to that slide. Well, that's the opioid crisis I was referring to. Yeah. Not everything that can be counted counts. So not everything that you can count is necessarily important. So a lot of literature that is published may not be as important. But not everything that counts can be counted. So some of the very important things you may not be able to count. So you may not be able to prove with an RCT that you need interdisciplinary clinics because they provide better management. All that can be done in some kind of roundabout way. But you can see by not having interdisciplinary clinics, so you don't have any numbers for it, but you can see what happens. And we have to keep our senses open to what happens in the society as doctors. Not just confine ourselves to, there's absolutely no getting away with that. You have to still be able to read the journals and get trained and, tick all the boxes there. But we have to, in the spirit of true interdisciplinary way of working, we have to be able to entertain the ideas of the feedback we get. And that may include personal experiences. My mother, who's sadly passed away, God bless her soul, I had an experience of going to the hospitals about 5 years ago now, and I got a perspective that I never did being a doctor. I'd never been that unwell myself, but that changed a lot in the way I think. And that wasn't like, something that I did not know about, but the way I could reflect upon was completely different. And I'm sure, I know that I'm not unique in that. Everybody has that experience. And a dear one, so we've got, and by the way, I just mentioned one little incident that would also reinforce the idea of a good interdisciplinary pain team. So she went to Shifa Hospital in Islamabad, and she had a fractured neck of femur, and she had a femoral nerve block within minutes of arriving there, and it worked fantastically well. And I met her a few hours later because I flew from Abu Dhabi, and she said, one of the best things she liked about it, she was in terrible pain and the pain went away. And she was ever so grateful. So when we see a paper, we have to see what limitations there could be. And a lot of literature published is not very high quality because there are scientific methods to construct an RCT. We've got to be able to train ourselves. It's very worthwhile to train yourself to be able to recognize where the flaws might be in any literature or any data set. And mostly what they do, these negative or positive, like the excellent studies that was mentioned in the last talk, we get average results from the trials And there's so much variability that we got to be, as clinicians, we got to be able to bridge that gap ourselves with our best judgment and our own training. And this is really important when we have interdisciplinary methods. So now, I think it's done more or less. Just most of my talk was already covered. I had great experience with using StartBack as a screening tool. It's validated. And yeah, just this last minute. And we had some fantastic results. So it's a screening tool. It is great for interdisciplinary working. It's for low back. You could add screening tools for anxiety, depression, things like HAD scoring system, and these things are validated. I think the key in developing an interdisciplinary approach, well, Lancet had a great series about what works, what doesn't work. For fibromyalgia, you have like first, second, and third line, and you'd see that from the second line onward, so not everyone is as severely affected, and you could have like more psychological input at the later stages of treatment. So there's a variety of ways. You can have flexibility when you design your interdisciplinary clinic. You can have flexibility in that. IASB recommends three levels of clinics, which are a multidisciplinary pain center, which is basically interdisciplinary working, and it should have ability to provide or form guidelines, perform research, perform all the functions. And at a lower standard, you would have multidisciplinary clinics, which clinically would be identical, but minus the academic bit. And then you could have single practice pain clinics. Now, that's another area where we got to be very, it's not, just because a bad experience, there was an example of bad experience in US with a single disciplinary clinic, and they were not all pain clinicians, by the way. A lot of them were family practice, as they call them, or other doctors. But the role of the industry was sinister. We have to agree to that. I mean, that's been, it's not my view. They pleaded guilty to that. And that involved kickbacks to the doctors. That involved providing false information to the doctors. So we have to be careful. In the single practice clinic, you can still do a lot of wonderful work. And I've seen it go on. And you just got to be able to see where you need the help of your colleagues from the other disciplines. And when you run a clinic like that, you should have a referral system and be able to think in the interdisciplinary mode, because without that, it's very difficult to manage fibromyalgia patients and chronic low back patients. I think I'd end my talk there. Thank you very much for listening.
Thank you, sir. Our next speaker is a consultant in pain medicine, Dublin Pain Clinic Group in Beacon Hospital. He serves as an honorary lecturer in King's College London, and he's also a co-author for Essence of Anesthesia Practice, 4th edition, Dr. Wajid Mahmood.
Assalamu alaikum, and good afternoon, everyone. So topic of today is I chose as a persistent spinal pain syndrome. I'll try to touch the topic of as much aspects of the topic we can cover today, but I won't go in many details of every aspect, so that we get a taste of everything for further research. Just for a little introduction, this is the hospital I work in, and we have an independent clinic, Dublin Pain Clinic, where we 3 pain consultants work together. And this is the university I'm attached with the teaching, University College Dublin. Before we start, let me share you with a little glimpse of a case report. Cerebral palsy, we all know that how debilitating and difficult path of a life of someone to develop. A young lady who presented in our clinic in 2019 in a worst form of her back condition, was born as a cerebral palsy child. Even before she was able to walk during the rehab, she was advised to be using equinotherapy and was placed on the saddle of a horse. Even before she was able to walk, she started riding horses. And then it was the will which developed and reached to the level that twice in the Paralympic, she basically cross all the levels of excellence, and finally expressed Ireland in the first 10 positions. And then it was the third time when she again passed through the screening levels of Paralympics in 2011 and was about to reach in 2012 Paralympic. Just few months before, she got a terrible car accident. And that made whole scenario as worse as possible, hitting by a tractor trolley and the car was writ off. Since then, her battle started from 2012 till 2019. You can imagine how many places and healthcare facilities she has been through just to stand straight. The pain was so worse, even with the help of relator, which she used to as a child from the very beginning with the clutches, she wasn't able to stand straight because of the severe pain which she developed and end up in our clinic in 2019. Now, I will pause it here for the case report before we go back to the topic, which is persistent pain syndrome. We know that, spinal pain syndrome. Why persistent spinal pain syndrome? We've been reading about low back since long time ago, and different names has been given with the different variable conditions of the back pain. Then why we end up in persistent spinal pain? So this is the beginning of this ideology actually. Nick Christalis et al. And he made, they were almost experts from, 14 experts from all these countries who get together and say, well, the terminology doesn't match the actual problem in the form of failed back surgery syndrome. It does not explain, first of all, those people who have severe back pain without any surgery, first of all. Second is that, should we blame back actually or the surgery? So they finalize why they were so intense in this era after such a long time, while we were using the old terminology for a long time. The rationale behind was what happened a little while ago. That 2019 ISP revised the classification of chronic pain as a part of new international classification of ICD-11, which has been accepted by the World Health Organization. This includes the replacement of failed back surgery as chronic pain after spinal surgery. So that was the beginning, that nobody was happy. Again, we are stuck in the same phenomena. Spine surgery is still standing there. This is the way ICD accepted the classification, and we see that chronic primary pain was a separate first level, then secondary musculoskeletal, chronic neuropathic, and chronic post-surgical or post-traumatic pain, which end up in the third level as chronic pain after spinal surgery. But that was again not the right terminology to describe the whole sum. So they propose another way of classification with further correction in the scenario of the third one, where they put the label as it should be persistent spinal pain syndrome. And you can see from the arrow work, it connects almost all the types except primary. And that described the actual causation, that the name should be in this scenario. They used the Delphi process, which was used for, we all remember in 1990s when we basically properly labeled the terminology of sympathetic mediated pain as complex regional pain syndrome. So whole of that was a Delphi process of all these experts sitting together, proposing a couple of terminologies and then rethinking about them, and finally they propose persistent spinal pain syndrome. As we all know that 19 was the first time Mixter and Barr, they first labeled the name as intervertebral disc herniation, as a lumbago, and was also associated with the sciatica explanations. In 1970, we name it as post-laminectomy syndrome, and 80s, Burton spelled the name of failed back surgery syndrome. And then for 10 years, Ross and Wilkinson and Law, all of them in their research, they were using the same terminology. Ultimately, this terminology reached in Europe in 1998. And we can see here that how much this terminology has been used from 1981 till 2018 in different research papers, widely used and accepted. it was not only the terminology being understood with this title, but also, as we understand insurance system and everything, they need that name to get approval for certain interventions and devices to be implanted. In 2015, something different happened. One of our colleagues, Mr. Al-Casey, basically he presented this article, a very nice one, to say that why we are thinking to find a blame game. Who is actually responsible? So now go back to our actual topic. I will briefly describe all the elements of that. We all know that genetic predisposition is always there, psychosocial, behavioral problems, mechanical issues, inflammatory infections, all of them, one of them or together can generate the phenomena in the spine. Factors are, as we know, specific to patients as well as surgery-related involvements of techniques, and during intraoperatively, they all trigger to make this phenomena. As we know, broadly speaking, the mechanics which are involved are nociceptive, neuropathic, and nociplastic. Now, prevention is there for everything. As much we can squeeze in to reduce the chances of developing this phenomena. First of the prevention is false expectations. There are certain terminologies which quite spoken regularly in our conversations and in the culture society is just like painkiller, which doesn't exist at all, which is not the source we want to build actually. Similarly, patient comes to the clinic and say, I want to get free from the pain. So these are all wrong expectations which definitely make huge barriers in terms of the actual treatment. And when the goal is set wrong, where we will reach in the end, we'll reach nowhere. In terms of surgeries, a lot of things has been tried. There is availability of evidence regarding mitomycin, steroids, non-steroidals, and role of statins. Biomaterials has been used in the surgical techniques as well as collagen and lipid grafts, barrier jellies. In short, we want to reduce fibrosis from surgery, which is the main phenomena which happen after surgery. Of course, prevention of psychological and social stresses has a huge role. In very short term, there are two important elements, key elements for the whole management plan that, as my colleague discussed very nicely, multidisciplinary as well as interdisciplinary. And I like the point he described that we have to think interdisciplinary way. It doesn't need to be under one umbrella or one roof when we are not thinking same way or together. So the same way as we run our clinic, that definitely we can't bring everyone in the room and still probably not able to convince them to think together. So we work in collaboration as remotely. In this era, it's not difficult at all. With all the communication ways we have developed that, in our clinic, we have 3 psychologists, 2 hypnotherapists, a team of physiotherapists, neurologists, rheumatologists. So when I count all of them which work with our almost every patient, there are 10 different colleagues. But not even sitting together, we still are connected and use the interdisciplinary approach, which actually bring the result. As my colleague described, it definitely save us from getting bias of the effect of industry, because they are market people, they have to sell their product. And if they are doing this to influence us, they are doing their job right way. It is our task and our duty to think interdisciplinary way or think independently that are we biased or not. And definitely interdisciplinary way is a path, provide us some safety from that problem. Now, pharmacology-wise, we all know and we all use these medications which have their certain element of role in specific problems related to back pain. But yes, we know that evidence is not great anyway. Specifically when the whole emblem of persistent spinal pain is developed, which includes all the elements of that. Recently, I was reading about some novel research which is going on, and I wish in coming few years we'll be able to have some medications away from opioids and all the routine medications which we find not helpful. Even yesterday, our colleague was telling that number need to treat for opioids is even 20, which is far less than the other medications we use anyway in chronic pain. So there is one project which was launched in Las Vegas and Nevada and still going on. It was Jan 101, is a formulation name at the moment given to that research product. They have done the first level, which was a good success, and the second level is in 2B phase trial, which will hopefully start in few months' time. So it was a trial started to help this extreme severe pain which started in the limbs secondary to peripheral arterial disease. I was trying to find the actual chemical nature of the product they are going to prepare, and they're using it in human trials now. So basically that is a sodium nitrate, and we all know it's a vasodilator. So vasodilators should have been having a role in improving circulation, and once circulation improves, the pain related to it should improve. It's not only that, they are also thinking that there is a role of imbalance in demand, supply, and perfusion of the area which develops pain. So there is an argument that it will be later on be tried for other types of chronic pain as well. The other I like to mention is the Vertex project. So they have been focused on doing research on sodium receptor V1.7, 1.8, and 1.9. And we all know as that the trigger and the start of action potential start in sodium channel from V1.7. So they made a chemical product for research, which is labeled as VX548. So basically what it does, it is specifically blocks sodium channel V1.7. Again, they have done the first trial as well. First human trial has been completed, and the second is going to start soon to see the further outcomes. So hopefully again from this end also we'll be having a medication which will specifically block the specific sodium channels which are involved in the generation and development of chronic pain. 1.8 sodium channel has been addressed as well, and there's another product they have made which will be soon start for the level 1 trial. We all know that it's always established physical therapy and exercise has a huge role. And now we have even Cochrane systemic reviews available to express the benefit of that. Psychotherapy and psychological therapy is widely described into two major forms of cognitive behavioral therapy and meditations. And now we have quite sufficient evidence for that. I specifically want to discuss these two topics as a separate element. I'm sure my colleague has covered all that anyway, but to be honest, this is thing which we can't say that it is not available to us. There is no one or any remote area of the world where we don't have availability to apply our patients with this cognitive behavioral therapy or meditation. Everybody is doing some type of that, and if it is not the integral part of our interdisciplinary team, pain management, we are not going to get the results at all. And why is it that? Because we know that they have a role to play which we need to cover. Now, in terms of pain interventions, at this stage, we have a huge list of pain interventions. According to availability of the facilities where we work, we should accordingly optimize that and use it. We always say when we reach the guidelines, they are coming from this part of the world or that part of the world, but all these things are not available. Specifically, even now when we come back home and see that, okay, how these guys are managing pain when there is no availability of stimulators. But yes, whatever we available, are we using it sufficiently? I don't think we are using it appropriately. Because not everyone need that. Even I see 100 patients a week. How many patients I place spinal cord stimulator? Only 30 a year. So it doesn't mean that this is the only way. Guidelines are there to show us the path only. And if we haven't developed, this will be my humble request to all of our colleagues that we should have our proposed institutionalized protocols based on the guidelines, according to the availabilities we have, and then apply that, please. Then we will see the results, definitely. Epidural injections, facet procedures, sacroiliac joint, we all know their benefits and it can be performed easily. Epiduroscopy, adenolysis has been trialed, neuromodulation, intrathecal delivery, drug system, and surgical revisions. Among these procedures, intrathecal drug delivery system, I have very less experience for that. Because the area I chose to practice in chronic pain is not cancer pain. And I'm not fully satisfied that other than cancer pain that we should apply intrathecal drug delivery system. I was recently reading there is another improvisation in the technique of PRF, in which they treated patients with persistent spinal pain by placing an electrode in the epidural space through a specific catheter, what they shown exactly, which we see in this diagram, that this is the difference of electrical field which we are looking for. What we do with the nerves is to modulate them by application of an electrical energy there. So when we do just PRF through the classic approach, we get this level of electrical field. That's why the results of this electrical field cannot be comparable to this big field. Well, it's not a huge research they have done, a big RCT. You can see the number of cases are not huge, but it's an element of further look into it and do research. As we all know, spinal cord stimulator is been keep growing from the last 50 years, and more modalities are coming on the way. Basic description of that, we are dealing with electrical energy, and according to our old understanding of physics with the Ohm laws, what we have is a voltage and a current. We have a pulse width of that electrical current, a wave and amplitude, and all these parameters. I still like to program patients with the old traditional way. I know that some of the companies like Boston Scientific, they have predetermined methods, but when you actually do programming, you learn more. When it comes to spinal cord stimulator, doing a procedure is every person sitting in this can do it without any trouble. It's an access to epidural space only. And we all place epidural catheters. Over here, we are placing a lead. With a little bit mild changes in procedure, everybody can perform. The actual role and benefit of spinal cord stimulator comes when we program it properly, when we place it for the right indication, when we choose the patient with the right understanding. So in this diagram, they have nicely shown that the traditional one, previous one was paresthesia-based spinal cord stimulator. And then we developed higher frequencies to develop paresthesia-free spinal cord stimulator. And then the burst came in with the specific waveform and the burst of 4 or 5 waves together, which were more near to human physiology. Now, high frequency has been used, Sansa trials, Sundust trials, they've been available to review, but to be honest, they're still working more to describe it a good way of management for neuropathies, not for low back pain. DRG is more specified, and when the dermatomal radiculopathy or radicular pain is there, it shows a good promise. But are we still stuck with, or it is improving also? It's tremendously improving. Even if we don't have now to start it here, but we need to understand, because the technology reached there one way or the other, and it will be there. The latest advancements in which we are looking towards spinal cord stimulator, one thing is definitely the waveform. As we all know, we started from very low frequencies, 40, 60 hertz, and now there is availability of 10 kilohertz frequencies as well. It's not only the frequency numbers, but the type of waveform has been improved as well. And the potentiation and sending together a couple of waves together, which basically burst DR who developed, has been in further improvisation. And now they are towards doing and providing less electrical energy to get the better results. Artificial skins has been developed and been in the most of the practical laboratory level. We have also neuro-restorative devices available as well. I'll show you a little example shortly. Closed loop systems are available, which are closed loop not to the patient but to the technology itself, that we can reduce the use of charge and increase battery life. Implantable electrodes with the jelly type of liquid electrodes has been tried as well with a good success. And implantable electrodes and their technology is improving almost every year. So in short, persistent spinal pain syndrome describe complex clinical condition and promote effective treatment. Pharmacology, management, and redo spine surgeries have actually shown a very little evidence. But physical therapy combined with psychology, epidural adenolysis, RF interventions specific for facet-mediated, and especially spinal cord stimulator implantation has provided a good evidence to treat persistent spinal pain syndrome. This is just an example. They place a chip in the brain with the 64 electrodes and connected it to our routine spinal cord stimulator. And this gentleman, who from last 10 years was not able to stand from the chair, was able to stand and walk, even was able to take the steps on the stairs and do some difficult tasks as well. Now we go back to the same case report, the lady which was not able to stand straight. For her, standing straight was such a huge bounty, which she imagined is everything for her to achieve, being a sportsman in nature. After placement of spinal cord stimulator, she was able to stand straight. And from later, she was able to manage her walk with simple one clutch. Thank you very much.
Thank you, sir. Our next speaker is Professor of Anesthesia, Pain Medicine and Surgical ICU at Foundation University School Health Sciences and Fauji Foundation Hospital, Rawalpindi. He was former advisor in anesthesia and pain medicine at Armed Forces of Pakistan and has contributed for the development of anesthesia and pain medicine specialty. Sir, we are incredibly fortunate to have you over here. Professor Dr. Major General Liaquat.
Bismillahirrahmanirrahim. Good morning, everybody. The hospital where I am working is a unique trust hospital because it don't take any donation, neither from government nor from public. How it happened? Because the founder of the hospital was a very wise person. He was not a doctor, was an administrator. So the funds available to him, part of that he invested in the industry. As the industry grew, this small hospital grew. Now it is almost 100-bedded tertiary care hospital, Pakistan's biggest artificial limb center, medical university, medical dental college, allied health colleges, and some other institution, and 7 peripheral hospitals, including one at Lahore. So as far the topic today is concerned, the Bertolotti syndrome, the first case we reported March 2020, and our team searched, that was the first case we reported here. The patient was a young orthopedic surgeon. In fact, he came to my clinic that I am having a severe pain left SI joint, and it is not getting better. It started when I was doing some exercise in the gym, and I have taken a number of analgesic. Tomorrow I have a long case to be operated some corrective surgery. Please inject something into my left SI joint. In fact, I was also carried away, but we did a quick assessment, and then we found the pain was quite severe, 8/10, and it was radiating up to the ipsilateral knee joint, and then we examined the patient. There was tenderness in almost SI joint area, and the Faber test, and then sacral thrust test, and other tests for SI joint we do, pelvic compression test, they were all positive. And we were ready to inject for SI joint, but when we examined the patient under fluoroscope, and we could see enlarged transverse process L5 on the left, and which was making a pseudo joint with sacral L. I informed the patient and counseled him, and he was also fascinated. Then we re-examined the patient and marked the area. In fact, it was a severe tenderness at that pseudo joint area. And we injected 40 milligram triamcinolone with 5 milligram abocaine, total 6 ml. And when with doing all our protocols, like doing informed written consent, and then applying the vital monitors, IV line, giving some sedation, we use midazolam 1 or 2 milligram. And when we turned the patient from prone to spine patient, almost after 10 minutes, he said, my pain has gone, and I will be able to do surgery tomorrow. In fact, he did the surgery next morning. And we advised anti-inflammatory for 2 weeks, and we assess the patient up to 1 year, and he was pain-free without any analgesics. So, as the British novelist D.H. Lawrence says, that what the eye does not see and the mind does not know does not exist. As we diagnosed the first case, during next 4.5 years, we diagnosed another 16 cases. I will just describe briefly this. Our second patient was 60-year-old lady, which was non-asthmatic obese. She presented with history of low back ache, radiating to both vertex up to inferior gluteal region. Since 5 years, with minimal effect of the analgesic drugs. So we examined the patient. There was local tenderness, and Faber test was positive, as well as the pelvic compression sacral test was positive. We advised the X-ray examination. Now we were little vigilant with our experience, and we could see Bertolotti pseudo joint and bilaterally. And we counseled the patients, and doing our routine protocol, which I just described for the first patient. We injected the patient both of the joint, and patient was pain-free, and we followed her for quite some time, as more than 6 months. Then the third patient was 58-year-old male, presented with low back pain for last 2 years, and it was radiating to the gluteal region, or to the right side to the mid-gluteal region. It was a severe pain. Again, there was tenderness, local tenderness. All the tests were positive. For this patient, we also did the X-ray, and there was a joint with the sacral ella on the right side, elongated transverse process. So we did the same standard protocol treatment which we has adopted for these patients, and patients was pain-free. And then the next patient, 65-year-old male with history of low back pain, radiating bilaterally to thigh and knees since 5 years. And there's some improvement with analgesic off and on. And we diagnosed on X-ray, again bilateral Bertolotti syndrome. We gave the same standard protocol and treatment, and patient was much better. Then, in fact, the analog score reduced from 8 to 2. Then the next patient was 35-year-old female with 3-year history of low back pain, radiating to both buttocks and thigh. There was some short-term relief with analgesics, and we did the X-ray. Again, it was a bilateral Bertolotti syndrome. We did the same standard protocol and treatment, and patient improved tremendously. And we recorded the giant involvement in all these 17 patients. Out of 17 patients, and if you see, 11 was unilateral and 6 was bilateral. And as far as the joint involvement, pseudojoint between transverse process and ala sacrum, they were 8, 6, and right and 2 left. And with ilium, it was 1, and both with ilium. And sacral ala, there was 2 such joint. In bilateral, the pseudojoint with transverse process and ala sacrum was 2, where the ilium 3 and both with ilium sacrum was 1. We recorded the age, gender of the patient, presenting complaints, was score before infiltration and 30 minutes after infiltration and 2 weeks of the treatment. In all these 17 cases, and we found out that majority were female patient, about 59%, and same percentage was the young patient, less than 40 years of the age. And the presenting complaint in vast majority, almost 82%, it was just low back pain only. And in remaining 17.6%, there was radiation sometime up to knee and some up the calf. The VAS pre-procedure was average 8, after procedure less than 2, and after 2 weeks it was 1. There were 3 patients he reported within 4 to 6 weeks for second treatment. So as for publication of this case, first it was reported in 2022 but published in Epicare 21. Then a case series of 11 cases, it was published, reported in 23 and published this year. Then a book chapter was published in Advanced Concept in Medicine and Medical Research, Volume 5. And we have a still ongoing series, and 6 cases has been diagnosed after publication of these 11 case series. Still, we plan a revision of this case series as we approach to case 25. We all know low back pain mean discomfort of pain below the costal margin and up to the inferior gluteal fold. Chronic pain is when it persists more than 3 months. It is a very common disease, low back. Lifetime prevalence is 60 to 70%, and 20% of these patients pain persists after 1 year. And in young patients, this is perhaps the commonest cause of limitation of physical activity. And it has a huge burden, financial burden, both in developed countries as well as in developing countries. The common causes, mechanical like disc herniation, neurological like radiculopathy, neuropathy, etc., then systemic inflammation, or maybe local inflammation of soft tissue, disc, etc. But there are some uncommon causes like coccydynia and Bertolotti syndrome. Mario Bertolotti was an Italian radiologist. He was the first who pointed out the correlation between low backache and some anatomical abnormality at lumbosacral region. And he found that in some of these patients who have a low backache, there is enlarged L5 transverse process, which sometimes makes pseudojoint with the ala of sacrum, sometimes ilium, sometimes both of them, and it can be unilateral or bilateral. He suggested that the degeneration in these pseudojoint, they may be the cause of pain. He also suggests that this changed biomechanics can lead to the damage to the adjacent joints also, like facet joints, like SI joint, and even the disc degeneration because of change biomechanics. The incidence reported is about 4 to 8%, but in some studies you can see incidence up to 11% is. This is the type of low back pain which is relatively common in young people. Then Kestlavi was the one who classified this disease into 4 categories. Type 1, just a dysplastic transfer process, maybe unilateral, bilateral. In type 2, it is just incomplete sacralization and lumbaralization, maybe unilateral or bilateral. Type 3, it is a complete lumbarization and sacralization, making pseudojoint, and it can be unilateral, bilateral. And type 4 is a combination of type 2 on one side and type 3 on the contralateral side. It has been found in a number of studies that disc degeneration is 9 times higher in these patients as compared to non-Bertolotti patients. And the extraforaminal stenosis is incidence is also quite higher in these patients. As far as treatment is concerned, conservative treatment and NSAIDs, then physical treatment like heel immobilization, banana exercises, back blocks, core strengthening exercises. In some patients, they really work, especially mild to moderate cases. Then intervention like infiltration of local anesthetic and steroid, which we use in our patients. And if this does not work, then we have 2 options. One is RF ablation. The main nerve involved is L5, but in advanced cases, when the adjacent joints they are also involved, it can be L4 as well as S1. So we have to assess either have to do the ablation of 1 nerve, 2 or 3, depending on the situation. And some people has also used PRP for this case, as most of the degenerative joints. Then if nothing works, then surgery is the option. They either do the resection of the tonsil process or do the fusing of the this pseudo joint. This is one of the algorithm proposed for management. The conservative treatment must be tried. But if it does not work, then if there is a temporary relief with local anesthetic injection, you can have a prolonged relief. And if it is does not work, then consider other contributing or other associated problems like myofascial patient and SC joint arthritis or facet joint arthritis. They can be there. They should be surge pass. If there is a long-term treatment, you can continue improvement with the local and steroids, and you can follow the patient. But if it does not work, then you have 2 options. One is RF, which we just discussed. Other is the surgery, depending upon the situation of the patient. So in conclusion, Bertolotti syndrome should be considered in differential diagnosis of low back pain, especially in young patients. And conservative treatment works in some patients, but before going for surgery or ablation, as we found out, the local infiltration work in these patients. And the most important thing in conclusion, I want to say that SI joint is the commonest cause of low back pain. We all treat SI joints. Some of the patients, they don't respond well. They respond partially or they don't respond. Then at that time, we should be suspicious of some other associated issues. There may be a facet joint, adjacent facet joint, SI joints, and less common, there may be Bertolotti syndrome or sometimes even coccydynia. I have seen some low back pain patients, and finally we diagnosed the patient was having a coccydynia that lead to that incidence. As in one of the previous presentation, there was said some patient came with the low back pain, now it is going to neck. In fact, I have seen many such patients. This actually happens. And patient has, this young ladies, I've seen few patients, fell onto the buttocks during pregnancy or so in the bathroom, has a fractured coccyx, so changed biomechanics. She sits on one side, so develop pain. First it may be SI joint, lower lumbar facets, then this continues. And thoracic, I have seen finally in 5-6 years, even the cervical facet joint, they are involved. So this can happen. At least I have seen many patients. Actually, patient or patient family may not be lying. We need to explore other associated or allied injuries if treatment is not working and we are focused only one problem. Thank you very much. I have saved 2 minutes for you, which we have overused. Thank you very much.
Thank you very much for the learned speakers on this Sunday morning. A very important area, that is musculoskeletal chronic pain, that contributes in Pakistan. That in last days presentation of Dr. Mary Cardoza, that is second most common pain burden patients, and in Southeast Asia is on the 5th. So it's a very important topic we covered today, though it's complex. So I will invite few rapid questions, 4 or 5, because we are running little out of the time.
Would any one of the speakers would like to answer on that?
So that's why there is no evidence suggesting its role, even in the routine back pain. So acute radiculopathy, I have not looked at that evidence though, so others can comment on that.
And yes, please. Yes, Atif.
Doctor, the question you've asked, is there a basis for that? Are you aware of some literature or your personal experience or any, okay, is there a basis for your question? Are you aware of some evidence that is present? Sorry? Radiologist is doing it. Yes, people do a lot of things. Yeah, I mean, I happen to do, yeah. So because we've been asked to respond, my response would be that I did look at low back treatments, and I do not think there is enough evidence for it to be recommended as, it may be a novel therapy, it may be a developing modality, but as far as I'm aware, good level of evidence which has got large number of patients, because there are some criteria for evidence. It has to be like strong evidence, or even a weak evidence does not exist for it to be superior to placebo or the currently best available treatments. I think there is more evidence for other treatments that are practiced at the moment, including surgery and various forms of injections. They have better evidence from when I looked at the literature a few months ago. Ozone does not have that quality of evidence yet. There may be many reasons for it, not necessarily that it will not work. Maybe it works, but we do not have the evidence to be able to. I cannot practice it in my, I cannot incorporate it into my practice.
We have been using triamcinolone and methylprednisolone in combination with the local anesthetic for decades. During the last decade, it was discouraged that transparent steroid should be used. My second question is whether Decatran available in Pakistan is preservative-free or not.
Usman, please.
Yes, anybody who can respond?
which came out over the last 5 years, especially related to the adverse incidents related to the depot, the one which is not about preservative free, it's the, sorry, I meant particulate, yeah. Particulate versus non-particulate is the main key question. So the UK guidelines came with very clear consensus that anybody attempting to do any steroid injection in the cervical region, they must not use particulate steroid. In the lumbar region, it's individual's own discussion, clinical judgment. We commonly still use particulate steroid. And the studies are inconclusive about whether, in terms of long-term response, the difference between in the response between particulate versus non-particulate steroid. So, but the key nutshell is the cervical region. You have to be very. There are very clear guidelines that use non-particulate steroid.
Yes, same. We have been using a lot triamcinolone and non-particulate as well. Since we started our practice in 2014-15 in Pain Management Center, Command Military Hospital, Rawalpindi, we were all using particulate in lumbar region. Then gradually we shifted patients to the non-particulate as well. Results are almost similar, but for the satisfaction of the practitioner, as I personally using particulate in lumbar region and non-particulate in cervical region as well. And sometime if a patient having some issue, some kind of element of infection or multi-organ disease as well, I use. I don't know what's the theory behind, but we avoid particulates usually in that case, and that satisfies to the practitioner as well and the patient as well. We haven't seen much complications or any adverse effects of using non-particulate even in lumbar region as well. So in our practice, particularly as Usman said, that we use in majority of cases particulate in lumbar region almost in 95 to 99% cases. But whenever it's in the cervical region, we use it non-particulate, and it produces similarly good results, and patients are very satisfied as long as in the case of steroid is concerned. As far as Sir Liaquat's presentation is concerned, that was an excellent presentation, I must say, because low back pain is very difficult, very challenging to treat. There are a hell lot of areas we can miss in treating the low back pain, and we need to revisit the patient. For a clinician, it is a very disappointing when a patient comes to you and say, Doctor Sahab, aapne injection lagaya. I will phrase few words in Urdu, lekin kuch fark nahi pada. So this was very disappointing for a patient, for my foreigner my colleagues, that when a patient came to you after any intervention and he says that, doctor, you have put an injection and have got no relief. Rather, I have got zero relief. So it's a very disappointing situation for a clinician as well. For that, you need to counsel the patient. For that, you need to revisit the patient again and again.
Thank you, Colonel Rashid, for your valuable comments. Any other comment or question?
About Dr. Durrani's question. Decadron available in Pakistan is non-particulate. It is particulate free. It is preservative free, non-particulate. The other comment regarding the lumbar epidural transforamen injections regarding the particulate steroids, it is very clear guidelines that whenever you do a particulate steroids, you always have to do a live imaging to rule out intravascular when you inject a dye. Unless you do that, you cannot rule intravascular. Khalifa, which is here, we have around 35 cases in which lumbar articular dye injection was done, and we usually do a live imaging when we do transforamen injections. And paraplegia has been reported with lumbar epidural transforamen injections. So my humble request will be, whenever you do a particular steroids, even in the lumbar, always do live imaging when you are doing transforamen. And the other point is, there is no point whether it is artifadamki which is present on the left side or right side, it has been on the right as well. So right or left, lumbar or thoracic or cervical, you have to do a live imaging when you do a transforamen injection.
Dr. Liaquat, any quick comment?
Sir, as the debate is on the steroid, particular or non-particular. But the presentation was shown, it clearly shows that the result of the steroids is inconclusive. So, sir, Dr.
Just
Usman,
that,
what
that
do
was
you
mentioned by
what do you
Dr.
actually,
Usman Bashir.
do in your practice?
Concentrating on evidence related to degenerative lumbar spinal stenosis. In that context, it doesn't work. In acute radiculopathy, it has shown results for up to 3 months. The studies have not looked up, so long-term benefit is not there. So in the end, it is about the clinician's own judgment and the discussion with the patient. Because studies have shown the harms of repeat steroid injections. Because the pathophysiology, that's why I concentrate on the pathophysiology, which is degenerative. So it's not inflammatory. That's why it doesn't work.
Well, thank you very much. We put a gullet into the session, and I think we had a very fruitful discussion in the end. We are already running about 10 to 15 minutes late. So thank you very much for participating, and thank you very much for enjoying this session as well.
Thank you very much. Now it's time for a tea break, and we will be back by 10:15 over here, inshallah. Thank you. 11:15, sorry, 11:15.